surgeon of pride for Andhra Pradesh. May I request Padmashri Madam, AGK Gokhale to go ahead with his talk.
Respected teachers and colleagues, good morning to all of you. I thank Dr. Harita and all the people who are associated with the APCSI for inviting me to this place, which I always love to come to Guntur, as I told many times. Long time, since COVID, I have not actually visited for the last 2 years. And this is the first physical meeting I am attending, in fact. Now we all know this heart failure problem is a big problem all over the world, including our country, but I'm very happy to see in the last 10 to 15 years, so much attention has been brought to this heart failure in our own country, and many of us are able to give much more better treatments than before. Of course, it is not a problem just in this country that we are not able to give the right treatment to all the patients. Even the developed countries, actually all the so-called GDMT, guideline-directed optimal treatment is being given only to about 25 to 30% of the patients, including the developed countries. And one of the last options, of course, to these patients is a heart transplantation. In spite of more than about 1.5 lakh of transplants being done all over the world so far, in a country like this, which represents the second largest populated country in the world, we have hardly done a little over 1,000 transplants since 1993. The reason is, of course, that we are not aware when to refer these patients for a transplant. We are aware, today we are able to diagnose heart failure, able to give drugs. For example, take a state like this, Andhra Pradesh, where there are so many centers, so many cath labs have come up. I was talking to someone that it's almost like eye centers, which I used to see around. Today we have got so many cardiac centers, cath labs coming up, but there's not even a single center which is able to give a treatment of heart transplantation. So I think you all need to give a due consideration these days that at least we should help some of these patients who should develop at least one center in this state. And I'm Dr. I have seen many new faces here. I'm Dr. Gokhale, cardiothoracic surgeon working at Apollo Hospitals, Hyderabad, Jubilee Hills. My areas of interest include minimal access surgery and thoracic transplants. So the topic I'm talking, of course, is about when to refer for heart transplant in LVAD. And we all know the heart failure is a big problem in our country. And the rate, there are a few publications, of course, saying that the rate may be from the prevalence is 1.3 million to 10 million anywhere. And this represents, this is going to happen about 1% of the population. So let us say about 5 to 10 million of population is there with heart failure. It has been very well proven that 5% of these patients will definitely go into advanced heart failure. That represents anywhere from 50,000 to 5 lakhs of people with advanced heart failure in our country. And today we have established ways of managing these patients. The treatment of heart failure is medical. There is absolutely no doubt about it. I'm talking about a small group of patients who may advance to require a transplant or a ventricular device. Today we got beautiful drugs affecting the renin-angiotensin aldosterone mechanism, beta blockers, SGLT2 inhibitors, the latest ones to be added. And of course the heart rate limiting drugs. And when things are not still helping, some of these patients, you work on resynchronization therapy or defibrillators. But then some of these patients are going to advance. We know when someone reaches a stage D heart failure or NYHA class 4, the mortality in 1 year is almost 60 to 70%. Can we do something to these patients? Now, basically, the textbook description, you open about heart transplant, ventricular device, we see these things. A small percentage of indications include intractable ventricular arrhythmias, people with intractable angina, even though it is very rare for a coronary artery disease patients to think of a transplant. It's almost like a taboo for us in India. Of course, abroad they do it. And cardiogenic shock, very small percentage of patients with the post-EMI, post-cardiac surgery, you can keep them on assist device temporarily, look for a transplant. It will work out. But the commonest, of course, is advanced heart failure. It's a very easy term to say advanced heart failure, but what exactly is advanced heart failure is something which even people in developed countries cannot understand. And American College of Cardiology have published a few articles recently to them itself to say when to refer for a heart transplant, even in those countries. There are two steps in this. The first step is, does the patient have or is the patient approaching advanced heart failure? That's the first thing you have to understand when the person is not responding to the drugs properly. Now, there are many ways that you can have a lot of tables. One of the mnemonics is, I need help. That is what patient is asking, you people. And the thing is, I means inotropes. So the patient is requiring inotropes at present, are getting admitted, asking for dobutamine or milrinone because they are going to failure, not responding to medical management. NIH class 3, 4 are very high BNP levels, and end organ dysfunction. When you are giving diuretics, his kidney was okay before, but now with the diuretics, the creatinine jumping up to 1.8, 2.2. Now we are not able to increase it. That tells you that you have already crossed the limits of diuretics, and they are done in those centers. Cardiopulmonary testing, look at VO2 max. It is more less than 12 when someone on beta blocker, time to consider a transplant. For less than 14, not on beta blocker, cannot add beta blocker, probably time to consider a transplant. Another thing is look at heart failure prognostic indices like Seattle heart failure model and heart failure survival score. These things can guide us, and this you cannot practice. See, every day in, day out, you see hundreds of patients. It is not up to you to calculate those things. So when in doubt, please refer. And the third step they do is, do we have any contraindication for transplant? Not that every patient can go for it. For example, someone has got a high pulmonary vascularity. They do a right heart cath with a PVR is more than 5 wood units, PVR is more than 5 wood units, or say transpulmonary gradient is more than 50. So some of these sensitive things, they look at those things. And another thing, someone has got addicted to a drugs for a long time, not good. And someone has got a cancer in the last 1 year, or developed secondaries elsewhere. Obviously, if someone cannot live for more than 2 years because of other things, there is no point in considering a transplant. So, and again, age factor. For example, generally we say age of more than 70 years is a contraindication, but not for everyone. See, some of these patients are physiologically much younger and they are likely to live for another 10-15 years. So look at those things. Control of uncontrolled diabetes. So these are all the indications and contraindications. We go through them and see if this patient is fit for transplant or should we leave him without those things. Once we decide that this patient has got advanced heart failure and there is nothing more that can be offered and there are no contraindications, then we decide whether he should go for a transplant. For example, see, these are the guidelines given by through the ACC. For example, eligible for a I don't know, where is the point of this? For example, eligible for transplant or LVAD, the list for transplant, and then in meanwhile he gets sick, then we try to use a temporary or implantable LVAD. And for example, someone eligible for transplant but not for LVAD, then obviously list them only for a transplant. Someone eligible for LVAD only, implant LVAD. Someone eligible for LVAD but not for transplant as of now. For example, let us severe pulmonary hypertension, you put a LVAD after 3 months it becomes a reversible pulmonary hypertension. It has come down. They list them for transplant. So these are the things we can do for some of these patients. Right now in this country, we got at least 50,000 people to 5 lakh people who are likely to be benefited by these things. And we are not able to do that. The donors are increasing. You all know from Vijayawada, Vizag, and from all the places, hearts are being taken to either Chennai or to Hyderabad. So I think time for us to look at these things. And remember, see, every patient with heart failure, don't refer too early, don't refer too late. If you refer late, good results cannot be achieved. There is a golden window for it, wherein if you keep an eye on them, identify that they are sinking, the heart failure is worsening, drugs are not effective. That is what you have to say. I often get patients who are on deathbed, who are on oxygen and high doses of inotropes, BP 60, 70, creatinine is 3.5, no urine output. That is when they ask the cardiologists and the physicians, can we offer transplant? That is too late. It's a costly treatment. We have to balance out who is likely to get benefit. I have a patient at Vijayawada more than 12 years, doing very well after transplant, who was on deathbed but came in time, good time, and now he is conducting his business. We have patients at Chalakaluru, Tenali. What I want to tell you is, please keep this in the back back of their mind. When in doubt, refer to a center where these facilities are available and help those patients. Thank you very much.
Thank you, Dr. Gokhale, for an excellent talk.